chairman for research compliance in the Department of Medicine. He has been involved with inhaled substance abuse research for the past 30 years, and within this field has directed a combination of basic research, animal studies, and human clinical research focusing on the toxicology of inhaled marijuana and the biologic effects of delta-9 THC on the immune system. Everyone give a big warm welcome for Dr. Michael Roth.
Thank you, Jeff. It's been a nice introduction between these two ends of the spectrum, from the basic biology and the complexity of what the cannabinoid system is, and the clinical impact that patients are interested in terms of using cannabinoids and trying to understand what it is that they actually do. Right at that interface, and I think this dovetails with what we just heard, is that there's a public perspective, and actually it's not just public, it's a research perspective and everything else, that everyone knows that marijuana has been used for centuries, that it's used for a lot of medicinal purposes, and that it's a quote-unquote harmless or benign recreational drug. And so that's the perception that we operate under, both as people using it, the public, and also people who are involved in the field, because that's how everyone perceives it. And I put this cartoon up here because it's a nice description based on an old joke in which someone loses their keys and they're looking around at night for them, and what do they end up looking? They're looking across the street under the light post. Because that's the only place the light is. That's the only thing that we know. So we tend to focus on what we think we know and on the perceptions that we have. And so the perceptions here are that it has a lot of medicinal applications and that it's a relatively benign drug. But as you're looking here, this is somebody's, what are you doing? Oh, I'm taking my medication, using their joint before they're going to get in their car and go home and face all that nasty traffic, which obviously then is based on the perception that's common, but doesn't necessarily mean it's good practice or good medicine, or it's really what the truth is. You don't want to take your joint and get in your car and face the traffic. I think one of the perspectives that is important from the research component of practical marijuana use is the idea that marijuana is a delivery device. And it's really based on what we should all know in our hearts, even if it's not what we do, is that tobacco is a delivery device. Tobacco smoking is used to deliver an addicting drug for profit. Doesn't really have any other great useful benefits inherent to tobacco smoking. It's a delivery device. And marijuana, smoking marijuana, or taking marijuana extract and using it another way, if we think of it from this kind of abstract perspective, it's a device to deliver cannabinoids. So in order to understand what it does and how it works, we have to not focus so much on what we think we know about marijuana and its use, but more on the fact of what we need to know about a delivery device that is delivering, as we've heard, 100+ different cannabinoid molecules, of which are in varying representation in different strains and cultivations and formulations of marijuana and pot. So we need to think of it from the biologic perspective of understanding that biology as a delivery device. What is it that we're actually delivering? And then how do we need to study what that delivered stuff does to the body? So it's a little bit different perspective from the clinical one. I think we also kind of heard at the end of Ziva's talk also a lot of questions focused on why don't we have a lot more research? Why don't we try inhaled pure components and study them and do a lot of testing? And that has to do with one of the reasons that we've I think, started the affinity group in cannabinoid research and are having this symposium here, is that it's a very difficult process and very few people do it. You have to have the ideas, the facilities, the institutional resources and support. You have to, at the same time, have the outside funding and finances to do it. You have to pass all the regulatory hurdles, having just put my DEA license for research with marijuana in place, that it took 10 months to get that license after studying in the field for 30 years with it. And get the licensing, and then you have to get subjects, and you have to do it in a very rigorous way to control for all the variables. So this is a very hard field of research to get into. So as a delivery device of cannabinoids, and where it starts to transition into the biology, we're talking about its interaction with cannabinoid receptors. And then we heard from Ken's talk, CB1 and CB2, and we commonly think of these as the CB1, the central receptor, primarily focused on the actions and biology in the brain, where it's one of the most abundant G protein coupled receptors. And it has this suppressive effect on brain biology. And CB2, which shares about 44% homology, similarity, but is defined really by its binding affinity, which we call the peripheral receptor, because it's expressed at very low amounts in the brain at rest. Certainly when the brain is inflamed or activated or injured, it may increase. But CB2 receptor is expressed at a higher abundance in peripheral organs. And in my particular interest in the immune system, which is the peripheral tissue organ site that has the highest expression of the CB2 cannabinoid receptors, and one of the natural reasons to think why there's an effect of marijuana and cannabinoids on immune function. So there are hundreds of papers, and they're relatively uniform in their findings. So rather than going through a lot of the literature, I really can kind of just summarize that there is clear and reproducible immune suppression that occurs when you use either THC and most other cannabinoids that activate or agonists of the CB2 receptor. It's clear suppression of the immune system. It occurs in animals, and when you administer cannabinoids to them, and it occurs to humans and human cells when you study them in the laboratory. So that part really is quite clear, that the potential for significant effects of cannabinoids on the immune system is there because it's the highest expression of receptors. And when you test it in the laboratory in an abstract setting, it's an immunosuppressive effect. And it's almost all cases you can block the effects by having an antagonist that blocks in one way or another the signaling or biology at the CB2 receptor. In some circumstances, you can also get an effect by blocking the CB1 receptor on immune function. So there is likely a dual component of both the CB1 and CB2 receptors playing a role in immune function, but the predominant effect is due to this CB2 receptor. The other effect that's been reported several times on the immune system, and is one of the effects that's, I think, most touted in terms of cancer therapy, that cannabinoids can be toxic and cytotoxic. So you can kill immune cells and you can kill cancer cells if you administer high enough levels of cannabinoids. But the question there is really the relevance, because in these studies, the administration of a cannabinoid might be the direct injection in an animal, the equivalent of 50 to 100 marijuana cigarettes, and you're injecting it all at once and right into a tumor. So in that setting, there's no doubt that it activates pathways that lead to cancer death. And there's also no question that in that type of exposure setting, it can have very toxic effects with the death of immune cells and disruption of the immune system. But in a practical sense, that's probably not something that we think about as a practical likelihood of the effects of cannabinoids on the immune system. So whenever you're talking about immune activating or immune suppressing drugs, it becomes very interesting in clinical medicine at this point in time because we have a tremendous explosion in other immune activating or suppressing drugs being blockbuster medicines at the frontier of new medical therapy. And a lot of them have become very common medications. So if you look at tumor necrosis factor as an immune activating and inflammatory signaling molecule that's released by the immune system, there's Remicade, Humira, Enbrel, and 3 or 4 other blocking drugs which are common, used by lots of patients for rheumatoid arthritis, psoriasis, inflammatory bowel disease, autoimmune diseases of a variety of natures. So drugs that block the immune system may have a lot of therapeutic potential in terms of this whole host of autoimmune and inflammatory diseases. And certainly that's what we've heard a lot about with marijuana, that it's anti-inflammatory and it should have a lot of effect on these same types of diseases. On the other hand, you have to think of the risk component of that when you suppress the immune system, then these drugs, which are very potent at that, carry significant risks of activation of tuberculosis, fungal infections, pneumonia, bacterial infections, life-threatening, exacerbations of hepatitis and other viruses, heart failure, and a significant instance of suppressing your immune system so much that cancer takes off. So lymphoma and skin cancer occur specifically with these potent immune suppressive drugs. And that's the risk side of saying marijuana potentially is a potent immune suppressant, because it's this balance between benefit and risk. And we see the same thing in the flip side, immune activating drugs, which are the cutting edge in cancer therapy at this point in time, what we call PD-1 checkpoint inhibitor blockade medications for treating cancer. These are rapidly becoming the #1 approaches to treating cancer. So modulating the immune system certainly can be have important implications. Right now, immune checkpoint inhibitor therapy is the #1 treatment for lung cancer, surpassed chemotherapy. It is the #1 therapy for melanoma. It is probably the #1 therapy for bladder cancer. So manipulating the immune system is a very important and clinically relevant system to look at. But those drugs have the flip side of the risk. They promote autoimmune disease. Those patients develop, who are on these therapies, between 10 to 20% of patients who will develop diabetes, thyroid disease, adrenal insufficiency, skin changes, inflammatory bowel disease. Two flip sides of the same coin. And this is right at the intersection that there's an interest in cannabinoids. So these same issues really exist with studying cannabinoids and their effects on the immune system. They may be immune suppressive or anti-inflammatory, but do they carry a significant risk that might be harmful? And so really there's very little known about this, and it is an important area that we need to know. I'm a pulmonologist, lung specialist, and interested in immunology and cancer therapy. And so one of my areas of research is really at this translation between the biology of cannabinoids and their clinical testing and evaluation. And I'm going to go over just a couple of studies that we've done. This one over a number of years led by Don Tashkin, who's going to be giving the next talk on the effects of cannabinoids and marijuana on the lung. In this study, what we have done is we've taken subjects that we've well characterized as non-smokers, marijuana-only smokers, tobacco-only smokers, or marijuana tobacco smokers, or other substance users. And we've brought them in, all being moderate users, moderate to heavy users, brought them in, and then we've done what we call a bronchoscopy, where we stick a telescope down into the lung, down through the airways, out into the lung tissue, and we wash the lung out and collect the immune cells from the lung which are exposed to the highest concentration of inhaled cannabinoids when you're smoking marijuana. To look at what's the effect of that regular marijuana exposure that people ordinarily have when they use. So I'm not going to belabor this point, but just smoking anything produces inflammation. And in this slide, we're just here looking at the number of cells that we recover from a standard wash by the smoking group in millions of cells. And you'll see a non-smoker has 20 million. Our average marijuana smoker has double. They have 40 million cells. They have a lot of cells infiltrating the lung because they smoke marijuana. They're not smoking anything else. Tobacco smokers and marijuana tobacco smokers. When we look at those cells, these are the macrophages we recover from the lung. Normal. And then in the smoker groups, you start to see that they have these inclusions. So these immune cells in the lung are engulfing the particles and retaining very high levels of the inhaled smoke particulates. And in this case, when we extract from these cells, we recover THC and cannabinoids and metabolites from these cells. So that's what they've engulfed. So there's every reason to think that they might be affected if there's an immunological effect. So when we look at these cells in a functional assay, we just plate them in the lab after taking them right out of our subjects. And we stimulate them, in this case, with a lipopolysaccharide, a bacterial component, and look at their production of cytokines. And here we see that the cells recovered from non-smokers and tobacco smokers produce tumor necrosis factor and GM-CSF, two pro-inflammatory protective cytokines, a significant decrease in the ability of the cells in marijuana smokers. So this is not manipulating them, exposing them to any cannabinoids in the laboratory, just taking them out from individuals who smoke and testing them. And they are deficient in their capacity to produce these protective cytokines. On the other hand, immunosuppressive cytokine, TGF-beta, was normally produced. So there does appear to be, in these subjects who are regular smokers, an immunosuppressive effect that is turning off protective, pro-inflammatory cytokines, but not suppressive cytokines. We took these cells and we just threw in Staph aureus, common bacteria that especially relevant in lung, pneumonia. What we see is that when you take non-smokers, we're looking at bacterial killing over 120 minutes, and they nicely kill the bacteria. When we inhibit nitric oxide, one of the mechanisms by which they kill it, it reduces their killing. When we look at the marijuana smoker, they don't really effectively kill Staph aureus. So not only do they not producing the protective cytokines, but they're not actually able to kill bacteria in an effective manner. We block the mechanism that they might use to kill. There's no effect, because then this is just looking at expression of nitric oxide synthase, inducible nitric oxide synthase, that in the marijuana smoker cells, they don't produce it. Whereas in exposure to Staph aureus, normal cells do. So this all fits, again, with a pretty convincing evidence, and one of the few convincing evidence that there is in human studies of an immunosuppressive effect in marijuana smokers. And I think we have a few minutes left. This is just looking at actually taking fresh monocytes from a normal person, incubating them with THC in the laboratory has the same effect. So this appears to be mediated primarily by THC. All right, let me just go on. So we thought if this is immunosuppressive, we wanted to look at a practical application. What could this really do? How potent is this to the immune system? And so we developed an approach to look at modeling responses to vaccines. How does the immune system respond to a vaccine? And would a marijuana smoker have a normal response to a vaccine, or would their immune system be so suppressed that they don't mount a normal response to a vaccine, which would raise concerns about their ability to respond to infections or cancer or other things? So we take antigen-presenting cells in this assay, which are the dendritic cells, T cells from the same person, from a person who's been vaccinated to hepatitis B. We co-culture them, and we see just in the normal setting whether or not dendritic cells are able to stimulate T cells to respond to hepatitis B. And in the normal setting, the more stimulatory dendritic cells, the more T cells proliferate in response to the hepatitis B. If you take antigen-presenting cells that have never been exposed to hepatitis B, they don't stimulate a response. This is just a confirming. If we take dendritic cells that were co-cultured during their generation with THC, and then we looked at their ability to stimulate T cells to respond to hepatitis B, dramatically suppressed. So here's the normal, here's the dendritic cell that was exposed to THC. It's dramatically suppressed. Would fit along with what we saw in the lung. This is just taking cells in the laboratory. Just to keep on track of our time here, the animal models also suggest the same kind of effects occur and might be very significant. This was one animal mouse model done by a group in Florida where they gave one injection of THC, 4 milligrams per kilogram, and then they immunized the animals with an infection, Legionella pneumophila, Legionnaire's disease infection. But they gave them a small dose to vaccinate them, not a lethal dose. Came back 3 weeks later, no other treatment, they just got one dose of THC and a dramatic effect on their ability to respond, suggesting that, again, in these animal studies, we see this very significant effect. So we wanted to set up a human study. Would there be a practical effect? And I think what we did here was we took marijuana smokers and non-smokers. We brought them into our unit and we vaccinated them with hepatitis B vaccine. These were people who had never been exposed to hepatitis B or hepatitis B vaccine. They got a vaccination on day 0, at 1 month, and 6 months. And if they were marijuana smokers, they smoked 4 joints over a 24-hour period, and they were vaccinated in the middle to make sure they really had a significant exposure to marijuana, as well as their home use, because these were daily, regular users. Non-smokers did not get any marijuana exposure, and we wanted to see, this is a real-life test. Will marijuana smokers who get vaccinated have an impact on their vaccine response? The in vitro laboratory studies suggest they should. These are the responses. These were just the antibody titers at the different points during their vaccination, from pre-vaccination to post-vaccination. Non-smokers and marijuana smokers, an antibody titer of 100 is considered a good therapeutic response. And we don't really see any difference between these two groups. These are 9 individual subjects in each group that were treated. We looked at the hepatitis specific T cells, their proliferation, production of interferon gamma. We looked at cytokine release into the assays. No difference between these two groups. So despite knowing in the laboratory that we can produce immune suppression and seeing in the lung, which is exposed to very high concentrations, we didn't see it in a real-life test in marijuana users, which raises a double sort kind of question. One, it might not be as effective as an immune regulator as we think it is. On the other hand, it might also hopefully not be as toxic as we might be concerned by the laboratory and animal studies that suggest that it might significantly increase risk for infections. And so I'll leave it there.
Thank you very much.